Thank you, Patrick, for your very kind introduction. It is my honor to go through this important topic in APACC today. I have no conflict of interest to disclose. And okay. So I believe that everyone would agree with Lucette that cognitive impairment and cognitive decline in people with HIV is pretty multifactorial. And to simplify it a little bit, apart from irreversible brain injury that exists before ART initiation, HIV-related causes remain the #1 issue during the long-term follow-up. And in the antiretroviral therapy era, this issue can be further subdivided into considerations in maintaining the HIV suppression, ART neurotoxicity, and potentially residual immune activation that persists despite suppression therapy. And comorbidity is always a big concern. In the hand studies, the HIV-associated neurocognitive disorder studies, mood disorder, risky behavior such as substance use, and co-infections such as hepatitis C infections are frequently described. And as people with HIV grow older, age-related cognitive diseases such as neurodegenerative disease and cardiovascular disease will certainly come into play. And the biggest challenge here is we do not have a concrete idea on how the residual HIV pathologies will interact with age-related cognitive disorders. This outlines my presentation today. We will focus on modifiable factors applicable to all age groups of people with HIV. First, about the CNS conditions that could be improved with ART management. Then we will go through cognition issues in hepatitis C infection, as it is a well-recognized risk factor of hand. Lastly, we will go through the concerns linked to residual immune activation, neurodegenerative diseases, and vascular brain injury. This US-based study set an example on the importance of virologic control in terms of the cognitive outcomes in the ART era. The study evaluates the cognitive outcomes in people with HIV based on their HIV control status, subgrouping them as viral suppression, VS, low-level viremia, LLV, and virologic failure, VF, using a cutoff of 200 copies per ml in the blood. And in the cross-sectional study, the investigators reviewed worse learning and motor psychomotor function in the virologic failure group when compared to the suppression group. And longitudinally, individuals with persistent virologic failure continue to exhibit a negative change in their cognitive test performance over time, while the other two groups didn't, highlighting that insufficient HIV control is likely harmful to cognitive performance or cognitive function in people with HIV. And so how about cerebrospinal fluid CSF HIV escape? Is it a form of low-level viremia or virologic failure in the central nervous system? The definition of CSF viral escape varies, but the general agreement is that there is a higher CSF viral load when compared to that in the plasma in people with HIV on treatment. It can be a detection of CSF HIV RNA with plasma HIV suppression, or a CSF HIV RNA level that is 10 times higher than that in the plasma. And CSF HIV escape can be symptomatic or asymptomatic. For asymptomatic cases, it ranges from 5 to 10% in people with HIV on stable treatment, and usage of protease inhibitor-based two-drug regimen is frequently reported as a risk factor. And in a longitudinal study of asymptomatic escape, it revealed that persistent CSF escape is actually very uncommon. And and very much resemble a viral blip in the plasma. In the case of symptomatic escape, it frequently presents with acute or subacute causes. Common presentations include headache, cognitive complaints, neuropathy symptoms, and motor symptoms. CSF pyocytosis, that mean a high white blood cell count in CSF is common, along with the CSF HIV RNA detection. And it is highly treatable, and the best approach is ALT modification according to resistant profile. And if the profile is not available because of the low-level viremia in the CSF, antiretroviral agents with better CNS penetrating efficacy, the CPE, should be considered. As symptomatic CSF escape doesn't always come with ALT resistant in the CSF, so if the patient is presented with new onset symptomatic cases and there is detectable HIV RNA in the CSF, it is totally reasonable to proceed to ALT modification, even there's not a resistant strain detected in the CSF. Apart from insufficient virologic control, cognitive or neuropsychiatric complaints can also be related to antiretroviral agents. And among them, ephedrine and dolutegravir are most frequently studied due to their extensive use as a first-line agent. For ephedrine, the most commonly reported neurological symptoms include headache and dizziness, insomnia and vivid dreams, and impaired concentration. And for the psychiatric symptoms, that includes mood disorders, anxiety, and occasionally paranoid idea or hallucinations. And a lot of times, these adverse symptoms occurs immediately follow the ephedrine initiation and improve gradually afterwards. And individuals with high drug concentration in the blood may benefit from a dose reduction. For those who tolerate the drug really well, after the initiation, only a small proportion of them will develop new onset side effects or worsening of their ongoing adverse effects. For dolutegravir, there was a great concern of neuropsychiatric side effects following the higher than expected discontinuation when it first came to the market, with adverse effects such as insomnia and vivid dreams, and irritability, depressive mood, anxiety symptoms, and very occasionally suicidality. Subsequent studies reveal that neuropsychiatric side effects are less common and as initially thought. And they are usually mild to moderate in intensity. In the RV254 acute HIV cohort study in Bangkok, we compared the mood questionnaire outcomes among participants who initiate ephedrine or dolutegravir-based regimen during acute HIV infection. We didn't find any significant difference in terms of their mood score at 96 weeks after ART treatment. However, for older people with HIV, additional precautions against dolutegravir side effects is possibly necessary, as a recent study reports higher blood and CSF dolutegravir concentrations in older individuals. This slide shows studies that compare the cognitive impact of ephedrine and dolutegravir users, and the results are quite mixed. For example, one study reported stable cognitive improvement over 3 years in ephedrine user, while the other two studies demonstrate worse cognitive performance in ephedrine users when they are compared to lopinavir and dolutegravir users. Some studies examine the cognitive changes before and after switching ephedrine to other third agents. And while the first two studies didn't observe meaningful improvement after the switch, the two in the bottom did observe some improvement. However, such improvement in cognitive performance could be related to practice effect as well. And how about ART intensification in those with cognitive impairment? Two recent reports examined this question through an addition of maraviroc or dolutegravir plus maraviroc to participants' original ART regimens. Unfortunately, both studies did not observe a clear cognitive improvement at follow-up after the intervention, and neither study observes benefits in their secondary outcome as well, including improvements in plasma immune activation and axonal injury markers measurements. Their results highlight that probably an empirical ART intensification strategy for people with HIV with cognitive impairment may not be beneficial. So to summarize, while the switching ART because of persistent or worsening psychiatric outcomes or cognitive outcomes are reasonable, little evidence supports an empirical ART intensification because of cognitive impairment alone. And without, and especially in the case of there is no evidence of virologic control issues in the blood or in the CSF. Besides, setting up laboratory capacity on HIV RNA measurement in CSF could be useful for a workup of cognitive decline in people with HIV. Because of the time limitation, I would just focus on hepatitis C co-infection in the comorbidities. As hepatitis C infection is rapidly increasing in our area, and while the cognitive issue in hepatitis C infection is less discussed in literature. Extrahepatic manifestations are well-recognized features in hepatitis C infection. And from a CNS perspective, hepatitis C infection is associated with fatigue, depressive mood, and impaired attention and psychomotor function. Besides, the risk of cognitive impairment in hepatitis C infection is increased with low cognitive reserve. That means among those with low education or in those with pre-existing brain injuries. Among people with HIV, those with hepatitis C infection, hepatitis C co-infection usually exhibit worse cognitive impairment compared to those without. And in an MR spectroscopy study, change in CNS metabolites in people with HIV after acute hepatitis C infection can even be detected by the MRS spectroscopy sequence, highlighting the neurological impact of this infection. More recent studies also demonstrate the neurological benefits of hepatitis C treatment and eradication. First of all, a number of intervention studies observe an improvement in cognitive test performance following hepatitis C treatment. And these two neuroimaging studies further demonstrate changes in MRI brain metrics after hepatitis C eradication. The two studies, and together with the MR spectroscopy study discussed in the previous slide, highlight not only the neurological impact of hepatitis C infection or co-infection, but also the importance of implementing hepatitis C screening and treatment services along with the HIV service for the sake of better cognition. Lastly, we will briefly go through the issue of residual immune activation in people with HIV on stable treatment, and particularly how it may interact with neurodegenerative disease and vascular disease or vascular brain injuries. But I have to stress that these connections remain to be confirmed in HIV aging studies. In the brain, glial cells such as microglia and astrocytes are important housekeepers to maintain the neuronal health. Through targeting the translocator protein of the glial cells, the TSPO PET scan can quantify the level of microglial activation and therefore neuroinflammation. And in people with Alzheimer's disease, and other neurodegenerative diseases, a wide spread of cortical TSPO signal increase has been repeatedly reported. And TSPO binding signal is increased in people with HIV despite suppressive treatment, suggesting the presence of ongoing microglial activation. And these shared pathologies between HIV and neurodegenerative diseases raise the attention whether people with HIV could develop neurodegenerative disease at a younger age, especially in those with pre-existing genetic risk. In this regard, two older studies did find altered levels of Alzheimer's disease biomarkers in the CSF, including beta amyloid and tau. And with the availability of amyloid PET scan for Alzheimer's disease, a number of groups investigate the potential connection between HIV, cognitive impairment, and amyloid deposition in older people with HIV. However, by far, a general association is absent. Or in other words, cognitive impairment observed in older people with HIV doesn't seem to contribute by altered Alzheimer's disease deposition or pathologies in the brain. Compared to potential linkage between persistent intracerebral inflammation and neurodegenerative diseases, the concern on stroke and vascular brain injury originates from residual systemic immune activation and endothelial dysfunction in people with HIV on treatment. And these immune dysregulations include persistent T-cell imbalance in the form of inverted CD4-CD8 ratio and the persistently elevated plasma immune activation markers. These two mechanisms or abnormalities are known to involve in atherosclerosis development and progression. And clinically, people with HIV have 2 to 3-fold increased risk of vascular complications than those without. And such elevated risk persists despite careful adjustment of confounders. But unfortunately, early antiretroviral therapy alone is not useful to completely eliminate residual immune activation in people with HIV. And even among individuals who started ART during acute HIV infection, T-cell dysfunction and elevation in plasma immune activation markers persist as at a group level. But why we have to worry about vascular disease and cognitive health in people with HIV? In the general population, vascular brain injury is the second most common cause of dementia and present in up to 70% of dementia if dementia with mixed pathologies are taken into account. It is also a universal predictor of cognitive decline regardless of neurodegenerative disease status. From an epidemiology perspective, Asians appears to be more susceptible to vascular brain injury. And based on the latest vascular brain injury and vascular cognitive impairment model, cognitive decline related to vascular brain injury can be insidious onset and progressive following the accumulation of white matter hyperintensity lesions or silent infarct in the brain. And it could potentially happen without conventional stroke events. And by far, while we know that there is an elevated stroke risk in people with HIV, whether the residual systemic immune dysfunction will accelerate vascular dysfunction and vascular brain injury remain to be clarified. Lastly, I'd like to go through this neuroimaging study published in 2023. This MRI study examined the deviation between structural brain age and actual age among the participants. So conceptually, greater the brain age gap, worse will be the brain health. The study found that vascular risk factor in the form of Framingham risk score, together with hepatitis C infection and detectable HIV viral load, are the strongest predictors of brain age deviation. I believe that this is one of the best examples that to circle back to the idea of multifactorial nature of brain and cognitive health in people with HIV. And this study is also a good reminder about the importance of modifiable risk factors in our management in aging and people with HIV, and especially before cure and new interventions are available. So this is the end of my presentation, and I'm happy to take questions. Thank you.